صباح الخير يا شباب. بنبلش موضوع جديد اليوم. هو again من ضمن مجموعة older أو geriatric diseases، هو موضوع urinary incontinence, although it happens at different يعني ages. فالurinary incontinence ايش هو تعريف urinary incontinence؟ شو انواعه؟ diagnosis, different types, mechanisms. في عنا different types of. I'm not going to go into the details of all of these، فمشروحة بالكتاب، شارحهم في السلايدز انا، لكن again ما راح امر عليهم بشكل فيهم تفاصيل كثير. طبعا بهمنا تعرف الانواع وكانديكيشن انه كل واحد له ايش مستخدم، او كل دراج او كل ديزيز او كل نوع من urinary incontinence ايش هو البروبر تريتمنت وايش بيميزه عن النوع الاخر. ف simply involuntary leakage of urine and can be presented with lower urinary tract symptoms او LUTs اللي بنسميها different symptoms like urgency، راح نعرفهم بعد شوي، increased daytime frequency and nocturia. Urgency is the urge to void urine, while the frequency going to the bathroom several times during the day. If they go to, or the leak of urine during night, nocturia. And as you know, this affects the quality of life of the patients. It might lead to depression. These are the psychological complications, but they also might lead to perennial dermatitis because of the continuous contact of the skin with urine, and worsening of pressure ulcers. If they have ulcer in the area, also that will getting worse, and urinary tract infections and falls. So, about the epidemiology, is it prevalent? Is it rare? It's actually prevalent, and the peak in women at menopause, with a slight decrease in the age group 55 to 60 years. So the peak happens at menopause in women, and then steadily increasing prevalence after the age of 65. So the prevalence was estimated to be approximately 20 to 30% during young adult life, with a broad peak around middle age, 30 to 40%, and increase in the elderly, almost half, 1/3 to half of those patients in the elderly, they might have one type or more of urinary incontinence. So at least half as common in men as in women. So it's more common in women. Now, what is the etiology and the pathophysiology of urinary incontinence? See, this is the bladder here on the right-hand side. This is the bladder, and this inside of the bladder, or the anterior surface of the bladder, we call it urothelium. This urothelium is in constant contact with urine because urine is staying there. So that might be one of the etiology. So acetylcholine appears to be the primary neurotransmitter at the neurotransmitter junction in the human lower urinary tract. في lower urinary tract it seems acetylcholine كنeurotransmitter هو اللي بيلعب دور في هذه الحالة. وإذا بدنا نحكي specifically عن M3, the muscarinic, as you know, cholinergic receptors, we classify them as muscarinic or nicotinic. فال-M3 muscarinic receptor are the subtype responsible for both emptying contraction. In order for us to void urine, we have our bladder has to contract, so that force will expel the urine outside, and for both emptying contractions of normal micturition as well as involuntary bladder contractions. So this will restore our receptors. I mean these receptors are the target by a drug if they are working on M3 anticholinergic drugs. They're working on the M3 receptor. Another receptor is the stimulation of beta-3 adrenergic receptors. In the detrusor muscle, this is the detrusor muscle, which is the muscle of the bladder. It results in a smooth muscle relaxation. So if you activate beta 3 receptors, you will cause smooth muscle relaxation. And beta 3 agonists are used in overactive bladder and urgency. So overactive bladder, it means the bladder is continuously contracting. So we need to balance that by giving a beta 3 antagonist or agonist. So this overactive bladder will calm down or making some relaxation if they have excessive contraction. So to prevent incontinence, if you see here, we have two sphincters in the urethra. We have the internal urethral sphincter and we have the external urethral sphincter. So we have to have a coordination between the two sphincters, the distal and the proximal, or the internal and external one, must maintain adequate closure. So we need them to have adequate coordination and to close in coordination with the bladder contraction or relaxation. So the maintenance of a low intravesical or vesical pressure, it means the pressure of urine inside the bladder itself, despite increasing volumes of urine. So the volume or the bladder itself can accommodate more urine, so there is no leak. So this is a unique property of the bladder and is termed compliance. Compliance of the bladder means the low intravesical pressure despite increasing volumes of urine. And some patients can wait, and some of them they may not. So therefore, if we have that large volume of urine in the bladder and it still can accommodate, this is what we call it the compliance of the bladder. So it can accommodate more urine. And normal bladder emptying occurs with opening of the sphincter. So if you see these sphincters here with a volitional bladder contraction. Volitional bladder contraction, so we have to have those sphincters open, then the bladder contracts and the bladder will empty or void its content of urine. So bladder contraction occurs in a coordinated fashion and resulting in a rise in intravesical pressure. So if it contracts, then that pressure will force urine to get out. The rise in that pressure is ideally of adequate magnitude. So we have to have a magnitude and a duration to empty the bladder completely. So if that emptying is incomplete, this is also kind of one of the symptoms, right? As we said in benign prostatic hyperplasia, for example. So disturbances in the neural regulation of the bladder and the lower urinary tract, whether it comes from the brain, the spinal cord, or the pelvic nerves, often lead to characteristic changes in lower urinary tract function that may result in urinary incontinence. So it is under neural regulation, whether it's coming from the brain, spinal cord, or the pelvic nerves, as we just mentioned. So the mechanisms of urinary incontinence, we have abnormalities of only the urethra, including the bladder outlet and urinary sphincters. So it could be only the bladder itself or a combination of both. So think about the anatomical location of that urinary incontinence. Are we talking about the urethra with the sphincters also included with that part? Or are we talking about the bladder itself? Sometimes we have hyperactivity, sometimes we have lower activity of the bladder. So we will go through each one of those, and a combination. Sometimes the problem is due to both the urethra and the bladder itself. So it's a combination of both. So we have the first one. We will start with urethral underactivity. Urethral underactivity, think about the sphincters in that urethra. Stress urinary incontinence, we call it SUI, stress. So if you hear me talking about SUI, which is a stress urinary incontinence, brief bursts of urinary incontinence concomitant with exertional activity. المميز فيهم هذا النوع هو انه لو يصير في exertion or exercise or force like running, lifting, coughing and sneezing. So you will have inadequate urethral closure force. It's episodic and usually low volume of urine leakage happen. So المميز فيه انه upon exercise, that's why we call it a stress. When the body is exposed to stress, there's running or lifting, coughing, sneezing, etc. So you will have inadequate closure of the sphincters. Therefore, we will have low volume urine leakage in this case. The risk factors that might increase this incidence are pregnancy. During pregnancy, something like this might happen. Childbirth during delivery, menopause, cognitive impairment, obesity because of the overweight or the body, aging, natural process due to aging of the patient, and surgery. Sometimes the patients, they have prostatic surgery. So these symptoms of the SUI, they are enhanced by alpha antagonists, alpha blockers. We talked about them in benign prostatic hyperplasia, and the angiotensin converting enzyme inhibitors. And this is the most common urinary incontinence. Either the most common urinary incontinence would be stress UI. The second type, bladder overactivity. Think about now the bladder. We talked about the urethra, now about the bladder itself. It could be an overactivity. What we call it urge urinary incontinence. And urge urinary incontinence, it's a leakage of urine, often high volume, which differentiates it from the first type, which is the stress, associated with urgency, a compelling desire to void. Urgency, which means the patient cannot wait. He has that feeling or sensation of urgent need to go to the bathroom and void. So this bladder overactivity, it's related to the overactivity of the detrusor muscle of the bladder due to involuntary bladder contractions. So the patient cannot control these contractions. So if you see it here, this is the urge, as you see on the outside, severe contractions here of the urinary bladder because of the detrusor muscle overactivity or hyperactivity or contraction. So the overactive bladder, also we call it OAB, characterized by urinary urgency with the frequency. They go to the bathroom more frequently. And nocturia, some of these symptoms might happen at night with or without associated urinary incontinence. Bladder overactivity also happens with, as we said, with these symptoms. The frequency is defined as micturition more than 8 times per day. So if you see people, they go to the bathroom very often, it's more than 8 times per day, that's frequency. Urgency is described as a sudden, compelling desire to urinate that is difficult to delay. Risk factors include age. As the people that are getting older, they feel these symptoms more. If they have neurologic disease, and sometimes they might happen due to bladder outlet obstruction, like benign prostatic hyperplasia. Aggravated by diuretics, because diuretics also, they will induce diuresis, alcohol intake, and anticholine esterase inhibitors. The Other one is the urethral overactivity and or bladder or underactivity. So the second one we talked about bladder overactivity. Now we have bladder underactivity. So we have urethral overactivity, bladder underactivity. This will be so-called overflow. So the bladder is very active, underactive, and urethral overactive. The result, excuse me, the urinary leakage resulting from an overfilled, as you see here in the picture, the bladder is overfilled with urine, get distended or expanded, that is unable to empty because you have overactivity of the urethra. The sphincters are closed. Here, the sphincters are closed in the urethra, so therefore urine is not getting out. So another term related to overflow incontinence is called chronic urinary retention, or احتباس البول. So we have urethral overactivity resulted from prostate cancer. Again, as we just mentioned, it's obstruction in the urethra, or partial, or it could be sometimes complete, maybe that needs surgery, of course, resulting from prostate cancer, benign prostatic hyperplasia, surgery sometimes, or a neurologic disease. Therefore, we have to dig into the reason for that. So bladder underactivity, the bladder underactivity impaired contractility due to myogenic and neurogenic factors, DM and pelvic surgery. So it could be also medication induced. Some of the medications might lead to these symptoms, like increased urethral resistance. So the urethra is not relaxing or it's not opening, so we'll have overactivity in the urethra. So like alpha agonists, tricyclic antidepressants, decrease the bladder contraction due to tricyclic antidepressant use, calcium channel blockers, narcotics use, antipsychotics, and anticholinergics. So these will decrease bladder contraction, and some of these they increase urethral resistance or urethral overactivity. Sometimes we have a mixed incontinence and other types of urinary incontinence, mix of urinary incontinence in the same patient, such as they have a bladder overactivity and urethral underactivity. The bladder overactivity resulting in urinary incontinence, and we call it UUI, urge urinary incontinence or urinary urge incontinence. And we have the urethral underactivity or stress. As we just mentioned at the beginning, the first type is a stress urinary incontinence. We have functional incontinence linked to the primary disease process, such as dementia, cognitive or mobility deficits, and more than any extrinsic or intrinsic deficit of the lower urinary tract. So the problem is coming from another function of the body, like nervous system in dementia, or cognitive or mobility deficit in the patient. So sometimes that functional incontinence is coming from sedative hypnotics and narcotic analgesics. So they lose the ability to control their lower urinary tract organs. So the clinical presentation for UUI or urgent urinary incontinence, urinary frequency, as we just mentioned, more than 8 micturations per day, urgency with or without urinary incontinence, the strong feeling to or desire to urinate, nocturia, that's happening at night, more than one or more than micturation per night, and enuresis may be present. We have reflex incontinence when the bladder contraction occurs without warning and sensation is absent. So the patient doesn't feel it just happens without previous signals or warning. Urinary incontinence related to urethral underactivity, which is the stress urinary incontinence. As mentioned, urine leakage with physical activity or exercise. No nocturia happens at night because the body is already relaxed, so it's not under stress. And they have to use absorbent pads sometimes. The overflow incontinence, which is a chronic urinary retention. So the urine, it's one of the urinary incontinence, of course. The signs and symptoms for that is lower abdominal fullness, hesitancy, straining to void because they have to exert more pressure to void, decreased force of a stream and interrupted the stream, sense of incomplete bladder emptying, increased post-void residual urine volume. I have a question. So it's not normal to wake up and night to go to the bathroom even once a night. So the answer to that question depends on the situation of the patient. Let's say a patient had a lot of diuretics, for example. If the patient takes a diuretic at night, then that's normal. If the patient drinks a lot of a fluid, let's say a patient, he had 4 or 5 cups of coffee at 7 p.m., that's, again, it's normal to go to the bathroom in the middle of the night. But if the patient is used to go only during the day a couple of times or 3 times, but suddenly they are more than 8 times per day, and they also go wake up at night and go do the voiding, that's not normal if it happens this way more frequently. So it depends on how frequent it is. So patients with chronic incontinence may also manifest fungal infection of the skin because of the duration of contact of urine with the skin for a long time. Erythema may happen also in the perineal skin or area, and breakdown and ulceration of the skin. Therefore, neurologic exam includes assessment of reflexes, that they have no neurologic problem, the rectal tone, and sensory or motor deficits in the lower extremities. So the physician has to check all of these to exclude if there is a neurologic disorder, for example, in those patients. Now let's take one question for a true and false. Urinary incontinence can be presented with lower urinary tract symptoms like urgency, frequency, and nocturia. Yes or no? Yeah, let's go. Come on, guys. في سؤال على الشاشة عندك. Please hit yes or no. Yes for true and no for false. And the right answer, أنا سوري سريع لأنه عندنا هذا الموضوع طويل شوي. فالcorrect answer is yes. All of these three are signs and symptoms in urinary incontinence. So the next question would be about muscarinic receptors. So the M1 muscarinic receptor are responsible for emptying contractions and involuntary bladder contractions. يلا على السريع شباب، لسه في عنا 6 7 people that did not answer respond. الأغلبية جاوبوا no, which is the right answer. طبعا هي no لأنه حكينا ال M3 muscarinic receptors responsible for that contraction. والثird question راح يكون عن الnormal voiding. فالسؤال reads, for normal voiding the bladder needs to relax so urine can get out. يلا مين معنا؟ ليش لسه في ناس يعني لسه ملتهيين بأشياء أخرى؟ بدي الجميع يجاوب يا شباب. كمان في 8 people are not responding. 5 كويس. dropping 4. كمان في عنا 4 لسه ما عم بيجاوبوا. طيب والإجابة الصحيحة هي no. طبعا for normal voiding لازم يصير في عندي contraction of the urinary bladder, not not relaxation. السؤال الثالث أو الرابع هو عن urinary incontinence is getting worse with alpha antagonists and ACE inhibitors. والإجابة الصحيحة هي no في الواقع، لأنه حكينا الألفا agonist. بالعكس الألفا antagonist they can improve urinary symptoms، بينما الانتاغونست they getting worse. فهي الإجابة اللي بعكسها. What is the frequency, by the way? Frequency is a sudden compelling desire to urinate that is difficult to delay. لأنه هذا تعريف urgency هو the desire or the compelling desire to urinate that's difficult to delay. الفريكونسي هي عدد مرات الذهاب إلى الحمام طبعا. The next question: the following medications improve urinary incontinence: tricyclic antidepressants, calcium channel blockers, and antipsychotics. والإجابات توزعت طبعا بين 50-50 تقريبا. الإجابات تتوزع. طيب والإجابة الصحيحة هي إيش؟ طبعا الإجابة الصحيحة هي false أو no, because these drugs or groups of drugs they worse, they're getting the urinary incontinence symptoms worse. طيب نشوف آخر سؤال في هذا الجزء. reflex incontinence happens when a bladder contraction occurs without warning and sensation is absent. والإجابة الصحيحة الأغلبية جاوبوا صح طبعا. يس، الإجابة الصحيحة هي يس. بنكمل على urinary incontinence. و these medications that influence, this is a table of the medications that influence lower urinary tract function. فعندي diuretics والacetylcholine cholinesterase inhibitors, الالفا receptor antagonist. What is the mechanism of action or the effect of each drug? الكالسيوم channel blockers, الناركوتكس. وطبعا كل واحد منهم فاكيد مطلوبين معنا. I'm not gonna read everything بس تشوف الإفكت تبعهم. This is the differentiating bladder overactivity from urethral underactivity related urinary incontinence. What is the symptom? Like urgency, strong sudden desire to void. البلادر overactivity yes. urethral underactivity بيكون sometimes. فبنميز ما بينهم. It's kind of differentiating the bladder overactivity from the urethral underactivity. وايش related طبعا symptoms اللي بتكون urinary incontinence. We'll come now to the treatment of urinary incontinence, and we have a bunch of okay, thank you again, I really appreciate it. يعني desired outcomes, of course, restoration of continence. So this is the first desired outcome. We need to reduce the number of urinary incontinence episodes. We need to prevent complications that might happen from urinary incontinence, like ulcer pressure or pressure ulcers, nursing home placement, etc. A lot of complications, they happen due to urinary incontinence. And we need to minimize the adverse treatment sequences or adverse events. We need to reduce the cost. We need to improve the quality of life for our patients. So as you see, a lot of desired outcomes in this patient population. The general approach to treatment is non-surgical, non-pharmacologic intervention. Normally is the first line of treatment for urinary incontinence. Nobody prefers medications, nobody prefers surgery or invasive methods. So therefore, non-surgical, non-pharmacologic intervention would be the first line in treatment of UI. And pharmacotherapy, when we talk about the drugs, provides a better response when combined with behavioral interventions. Behavioral interventions, no medications, no surgery in this situation. And surgery when the degree of bother or lifestyle compromise is sufficient, and other non-surgical mandated or indicated. So surgery, we need it, of course, when the complications they get or the patient lifestyle get compromised and the non-surgical interventions are not desirable or ineffective, then the ultimate resolution for that problem would be surgery. Again, in pharmacotherapy, the antimuscarinic agents are the primary choice among medications. And inadequate response, if there is one agent give us inadequate response, adjust the dose or switch to another antimuscarinic agent, because we have several antimuscarinic agents. We will talk about them. So بلش ب non-pharmacologic, non-surgical treatment, which we said is the first line therapy, especially for those with mild to moderate symptoms and who don't want to take medications, patients عندهم comorbid diseases or conditions who are not medically fit for surgery. We can't do surgery for them. Those who plan future pregnancies and they don't want to go through the surgery or taking medications because they might affect their pregnancy outcomes, or those with overflow incontinence whose condition is not amenable or treatable with surgery or drug therapy, then we have to stick to non-pharmacologic, non-surgical treatment. And those who are delaying surgery, if they are just delaying surgery, they have to have something in hand before they go to surgery, or if they don't want to do surgery at all. So non-drug interventions include behavioral interventions, external neuromodulation, anti-continence or incontinence devices, and supportive interventions. And the behavioral interventions, they are considered first line treatment for stress and urge urinary incontinence and mixed urinary incontinence. That would include lifestyle modification, voiding scheduled regimens, pelvic floor muscle rehabilitation, External neuromodulation, on the other hand, may include non-implantable electrical percutaneous tibial nerve, extracorporeal magnetic stimulation, and neuromodulation normally prescribed when a traditional pelvic floor muscle rehabilitation has failed. يا جماعة again يعني الانترنت ضعيفة بتصير بعض الأحيان we can't do anything. يعني إذا في عندكم طريقة إنه أسرع الانترنت احكوا لي أو أعمل لك كونكشن كويسة يعني. فبليز إذا مش سامعني أنا في عندي ريكورد لو راح عليك شوية 1 2 سلايدز ذاتس اوكي لأنه بنرجع بننزلهم ناريتد زي ما هم بنحطهم على شكل فيديو فاللي راح عليه إشي بيحضره والسلايدز موجودين. فيعني أنا ما بقدر أعملكم أي شيء بصراحة لما بكونش في كونكشن. انا ما في عندي اي مشكله هون فالامور واضحه وسليمه. يعني اذا صارت في مشاكل بالكونكشن we can't do anything ف please don't يعني distract me. ال next one anti continence or incontinence devices. عباره عن devices ممكن يستخدمها البيشنت like bed alarms, catheters, pessaries, penile clamps, external collection devices. So these are, as you see, these are just devices that would help to resolve the symptoms of urinary incontinence. They are reserved for a special situation depending on the patient's urinary incontinence symptoms, their cognitive and mobility status. Sometimes if the patient cannot go to the bathroom, they are in bed. So we can use these catheters, for example, and depends on the overall health status of the patient. We have sometimes supportive interventions, such as physical therapy. Now, physical therapy, especially for those patients with muscle weakness. If they have muscle weakness and slow gait to reach the toilet in a timely manner, طبعا we have to do physical therapy for them in order to be able to reach the bathroom, in order to strengthen their muscles. Sometimes we use absorbent products. They will provide greater confidence in dealing with unpredictable urine loss. So the non-pharmacologic option is surgical treatment. So surgical treatment, again, will depend on the underlying abnormality responsible for urinary incontinence, whether is it the bladder itself or the urethra. Do we have underactivity or overactivity? Therefore, surgical corrections of female stress urinary incontinence or urethral underactivity is directed toward repositioning of the urethra and or creating a black board of support, improving the sealing mechanism and or creating compression or otherwise augmenting urethral resistance, mid-urethral synthetic slings, and injectable bulking agents. Those will increase the urethral resistance. I want you just to know that they have some surgical correction procedures for females. Artificial urinary sphincter, sometimes if the sphincter is malfunctioned or defected, especially in male stress urinary incontinence, restricts urine flow out of the bladder through supplementation of the urinary sphincter. In case of urge urinary incontinence, implantation of a sacral nerve stimulator or endoscopic injection of botulinum toxin. The bladder or other activity, we use in that condition intermittent self-catheterization or sacral nerve stimulation. In case of urethral overactivity, surgical resection of the prostate. So the solution for that problem would be to surgically remove the prostate. Now we come to the pharmacologic therapy, which is the mainstay of treatment here for us as pharmacists, is the pharmacologic therapy. Again, we talked about the antimuscarinic agents and the beta-3 adrenergic agonists اللي هو mirabegron are the second line drug treatment for relieving urinary or urge urinary incontinence symptoms and preventing its complications. Antimuscarinic agents, they will antagonize the muscarinic receptor, M3 receptor. Therefore, they would suppress premature contractions of the trousers muscle of the bladder, will enhance bladder storage. And instead of leaking the urine, the bladder will take the urine for or more volume for a longer period of time. Therefore, that will improve urge urinary incontinence. They have similar contraindications, precautions, and side effect profiles, with incidence and severity varies within each individual agent. So they are similar in the contraindications, of course, and some of the conditions. Antimuscarinic agents, we said the choice therapy should be based on patient characteristics. Is the patient's age older or younger? Does the patient have other comorbid diseases? Is the patient taking other concurrent medications? Is the patient able to adhere to the prescribed regimen? So we're worried about the compliance or adherence of the medication. If we give them a complicated dosage regimen, of course, they're not going to comply with it. And the efficacy outcomes in this condition is the reduction of the mean number of urinary incontinence episodes, decrease in the number of micturations per day. Instead, we said sometimes they have more than 8 times per day. If we can reduce them, that's a predictor of the outcome, the results of a treatment, that our treatment is effective in this case. Increase of urine volume voided per micturation, which means they have almost complete bladder emptying. There is no residual volume in their bladder. That's what we are worried about. And I have some more questions for you before we move to the next part. So, the desired outcomes of urinary incontinence include restoration of continence and reduction of the number of urinary incontinence episodes. يلا في سؤال يا شباب. سؤال على الشاشة للي مصحصحين معانا. طيب والإجابة الصحيحة هي يس طبعا كانت الإجابة. بنيجي للسؤال اللي بعده، والسؤال اللي بعده بيسألنا عن non pharmacologic treatment. Non-surgical non-pharmacological treatment is appropriate for those who plan future pregnancies. والإجابة الصحيحة هي يس طبعا، لأنه حكيناها من شوي، فبيكون عندنا الإجابة الصحيحة yes. So the last question in today's session would be about anti-continence devices are prescribed when traditional pelvic floor muscle rehabilitation has failed. طيب والإجابة الصحيحة هي خطأ طبعا، هو ما مستخدمهم ال traditional when the pelvic traditional floor muscle rehabilitation fail. This is incorrect. طيب نكتفي لهذا القدر يا شباب اليوم، وإن شاء